Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Today I'm speaking with two principals from the Illinois Health Practice Alliance, IHPA, a clinically integrated behavioral health network promoting health, recovery, engagement, and choice to clients across the state of Illinois. David Berkey, Chief Executive Officer, and Gilbert Lichstein, Chief Operating Officer. Guys, welcome.
Thank you, sir.
Thank you.
Gilbert, by the way, when I started this, I asked for the proper pronunciation of your last name. Did I get it right?
Lichstein. Thank you.
I got it wrong. Wouldn't you know? Anyway, my apologies. Anyway, I'm glad I asked. Anyway, guys, thanks so much for taking the time. Really do appreciate this. First off, David, if you would give us some background on IHPA, when it was founded, what gaps in the marketplace it filled and continues to fill.
Certainly. The Illinois Health Practice Alliance was founded in 2018, and it was founded as a vehicle to help the community behavioral health provider community in Illinois transition into value-based payment contracting with Medicaid managed care companies. So we are a joint venture between a major insurer and a subset of the 120 plus community mental health and substance use treatment providers that are in our network. And our core focus is to negotiate managed care agreements for value-based payment terms with the Medicaid managed care companies doing business in Illinois, and to ensure the success of our providers in delivering care under those agreements.
You mentioned integrated care, which is obviously fundamental to what you do. David, why is it important that primary care and behavioral health care be treated in an integrated fashion?
Because we as humans have multiple needs. We have mental health needs, we have physical health needs, we have social needs in our daily lives to help ensure that we can live healthy and successful lives. And if we as providers just look at one subset of that without taking in the others into consideration in clinical care and care management, then we're only looking at a piece of the puzzle, not the whole puzzle before us. So to help someone maintain their mental health, they have to be physically healthy and they have to have their social needs addressed. So if you're homeless, your main goal obviously is to find shelter. So you can't focus on medication management or managing your diabetes or anything else before you address finding shelter. And oftentimes when you're dealing with clients that have serious mental illness, they not only have that serious behavioral health issue, but they have concurrent diseases that impact not only their mental health, but their physical health. So if you're chronic diabetic and you're not properly managing your insulin, and you're also suffering from schizophrenia, one can impact the other and collectively make your individual circumstances far, far worse. So one of the things that IHPA is able to do is in our contract negotiations, we ask each one of our payers to give us 18 months of full claims data for the members that are attributed to our providers for management. So our clinicians can go into our care management platform and get a full view of everything that's happening with that individual, their physical health claims, their behavioral health claims, any other subset of claims that are touching and impacting that individual's care. And they can also use those tools to help better manage that member and ensure that there's effective communication between the behavioral health clinicians and their primary care physician involved with that member, to ensure that all the members of the care team are on the same plane, understand the dynamics taking place in both of those circumstances, and subsequently doing the best they can to help ensure the health of that individual.
Yeah, no, it Perfect sense. In the intro, I mentioned value-based care, another core component of what you guys do. And just as an aside, let me mention that I want to ask you about that. I want to put that to Gilbert, that our audience or our intended audience is not just a specialist audience, a general audience. And we want to make them aware of the breadth of issues that Chestnut and the Lighthouse deal with. So, Gilbert, value-based care. First, what is value-based care?
Yeah, value-based care, in simple terms, focuses the treatment system on what people value most. It focuses it on quality of care. It focuses it on the member experience. One way to think of it is it's different from a traditional volume-based paradigm that treatment systems traditionally have. What we try to do, just again, keeping it simple, is we work to help people live without distress and impairment. We want them to be able to do the things they want to do with their lives. We want them to be able to live according to their values and goals. And what that looks like in practice is a framework of measurement-based care that makes sure people get follow-ups after they go to the hospital, after emergency department visits, and that they do things like initiate addiction treatment when there's an addiction issue and stay in treatment once they start. You know, thinking about it, when someone is hospitalized for a mental health condition, it means that that condition got so bad that it became an emergency. And we want to make sure that people can capitalize on the gains they make during a hospitalization when they get follow-up care through a community behavioral health provider so that they can stay on medications that work for them, they can continue with therapy, they can get proactive care to avoid future hospital and emergency visits, and they don't, and you know, not have a worsening condition with debilitating setbacks. The measurements we use come from a system called HEDIS, which stands for the Healthcare Effectiveness Data and Information Set. It's developed by the NCQA, which is the National Committee for Quality Assurance. It's designed to help benchmark health systems, funders, providers with respect to one another. And one of the upsides of HEDIS, of that system, is that it's able to orchestrate improvements in key public health priorities. So, you know, public health experts design these measures around priorities that they want to move the needle on. Another advantage is it uses claims data that already exists to drive and track those changes. So it's different from data that's derived from member surveys or member self-reported symptom inventories, which rely on members to be accurate historians and can also suffer from sampling biases because they only include data from members who were available and willing to complete the questionnaires. You know, what we're working with is a clearer picture of what's going on in the real world because claims data tells us something about all of the members we work with. A final piece that I want to touch on in terms of data is and something that's really important for people, observers of healthcare systems to understand, is a phenomenon called regression to the mean, which is a statistical property of outliers to become closer to the average over time. And what that means in a healthcare context is if you test an innovation by applying it to a population of outliers, such as people who are in the hospital much more often than everyone else, you're going to see a reduction in hospitalization just because of this statistical property of systems like this. It doesn't mean that your effect necessarily worked, and oftentimes that regression to the mean is mistaken for an effect size. The way that we cancel for that is by comparing the populations where we do an intervention to like populations that didn't have the intervention to prove that it was a real effect. And so when we're talking to you about reducing psychiatric inpatient admissions or all-cause ED visits, we're talking about a real effect because we've done that like cohort analysis.
Gilbert, thank you for that very thorough response. Next, I want to ask about social determinants of health. David, in defining integrated health, seems to have sort of touched a bit on social determinants of health. But Gilbert, if you would define for our audience what that is, what social determinants of health are, and why it's so important.
Sure. Yeah. Social determinants of health are non-medical things that impact a person's health. Structural things like poverty and inequality that lead to people having health-related social needs like housing, food assistance, transportation assistance. We believe that housing instability is a driver for many hospital admissions. What we see, looking at our claim system data is that there's a group of people in the Chicagoland area that are basically living in psychiatric hospitals a few days at a time, one hospital after another. That's something you only see if you look at claims data. We also know that transportation is a barrier for people following up on medical care, and even things like not having a phone, not having access to the internet. Ways that we've been able to address this, we've got a program called OnRamp, which is a state-funded program that gives providers a case rate to directly address a member's health-related social needs. So it's, we like to think of it as another tool that we give them in their toolkit for engagement. They can work collaboratively, creatively with the member to identify how that funding can help them make gains with their health conditions. And we found that the providers come up with really creative and constructive ways to do that. They help people get into more comfortable living arrangements. They help people get back on track with employment. They help people feel better about their health and how they function within their families. We've also, we have a partnership with Uber Health, where providers can order rides for members quickly and confidentially. And we did a light cohort analysis on that initiative, where we showed the availability of that resource alone for people trying to enter substance use disorder treatment had huge implications for their likelihood of future hospitalization, which makes sense when you think about it. People, that drive to get into rehab can be fleeting, and you have to strike while the iron is hot. People can actually relapse on their way to treatment if they don't get there fast enough. So just the difference of an easy to order ride that the provider can orchestrate gets people in treatment faster, it gets them help, and it reduces hospitalizations.
Interesting. What role does technology have in everything that you do, which is, say, integrated care and value-based care?
Yeah, David touched on it a little bit already. So, I think a good adage that we live by is what gets measured gets done. And so, we have a boutique technology platform that combines disparate data sources to give providers a complete picture of what's happening in the member's life outside their four walls. Before we got there, providers were relying on the member's self-report. Now, what we're doing is we're synthesizing something called admission, discharge, and transfer feeds, otherwise known as ADT, which is a standard system that the state has implemented for hospitals and other acute care facilities to report on who's been admitted to their facility and why. We assimilate that with information our health plan partners obtain in communications with hospitals and acute care facilities, and then we assimilate it later when we have it with claims data. It's a fire hose of information. The platform takes care of the hard work of interpreting and synthesizing that information and boils it down to a concise, actionable work list for providers to use. They can see immediate real-time care gaps to react to. We have ways in the platform of estimating how well providers are doing at closing the care gaps. We give them dashboards to see how they're doing. Before IHPA, providers could not see how they were performing relative to each other. They were operating in a vacuum. Now we can all see who the best practice leaders are. We can propagate some of their best practices to other providers. And I'll mention Chestnut at this point. And one of the great things about being in this role, we get to meet providers of a lot of different configurations. We get to see the innovative work people are doing. One thing that Chestnut has been done really well is reimagining the scheduling system for psychiatric services to manage that resource well and get people in quickly. They've also reimagined the way they distribute caseloads within the organization to help the members' needs get effectively. And so things like that, we're able to, with Chestnut's input, take that and scale it throughout the state and address access challenges. We've got a team of provider performance managers who meets regularly with providers, who walks through those dashboards. These are, up to the minute supportive conversations that are driving those quality improvement goals in real time.
Okay, next thing I want to ask you, Gilbert, evidence-based practices. Why are they so important in behavioral health care, and what can a network like IHPA do to drive implementation of evidence-based practices?
Yeah, so flowing from the previous question, evidence-based practices, evidence-informed practices, it is about using data obtained in research studies to drive the clinical approach that practitioners take. When we talk about behavioral health conditions, these are often conditions where there's not a biomarker for the condition itself. It's not like a primary care condition where you're trying to fix a broken kidney or a broken heart valve. Instead, you're relying on what research tells you about how to isolate the condition and how to treat it. And conditions, just to name them, mood disorders, anxiety, psychosis, addiction, motivation issues. Without evidence-based practices, the work clinicians do can become idiosyncratic and anecdotal. I think if you're working in these treatment contexts, particularly with people with chronic and severe mental health and addiction issues, one of the things you realize very quickly is a large portion of the people that you encounter don't necessarily want treatment or aren't sure that they can get better from their conditions. And for that reason, we're very focused on a clinical approach called motivational interviewing, which is really more of a conversational style. It's designed to enhance motivation, to change specific target behaviors. It could be drug use. It could be something like lack of adherence to a medical recommendation. But we think that, going back to what David was saying about an integrated care perspective, we think that almost every interaction, there's going to be a target behavior that the member touches on that they would benefit from changing, but they may not be sure that they want to change it or that they can change it, and that's where motivational interviewing comes in. So we do extensive trainings on that. The way that we are trying to go beyond now is by giving supervisors tools for providing structured coaching and feedback as they see the kind of responses that clinicians are giving, either in response to simulated client statements or the review of taped sessions. So it's important to have a didactic piece, but it's also important to have that structured coaching and feedback. We go beyond motivational interviewing. We talk about opiate use disorders. So really trying to increase base utilization of and adherence to medication-assisted treatment for opiate use disorders. This is a life-saving medication, and that's things like Suboxone and Methadone. People are much less likely to die from an overdose if they get those medications. We drive that through. There's a HEDIS measure that's associated with it. Historically, because the funding streams for mental health and addiction treatment were bifurcated, mental health providers aren't always used to looking for a substance use disorder. And so we're engendering that practice of looking for it, of linking the person to care for it. Once they start care for it, staying with care. And I will again say this about the Lighthouse Institute and Chestnut, really leaders in that practice of screening and brief intervention for substance use disorders. And then of course, Chestnut's leadership in increasing the availability of medication-assisted treatment. Final piece, research indicates that past experience of trauma undergirds a lot of health conditions, both primary care and behavioral health. We know from long-term longitudinal studies that people that had early adverse childhood experiences experience negative health outcomes later in life. We really drive providers to focus on helping members get care for trauma, and also using a trauma-informed approach throughout the agency with every member-facing person, because trauma has implications for pervasive implications for a person's interpersonal style, and it's important to recognize that as you interact with them.
Yeah, in fact, last week our Catalyst Substack newsletter, which complements our podcast, was all about trauma-informed care, and we're going to do a theme, several articles on that topic. David Gilbert, you've done an excellent job in defining these core concepts and principles. So, let me ask you, just sort of put some flesh on the bone, if you will. What does a typical day look like for an IHPA provider? And then I'm going to ask you about what a typical day looks like for someone who benefits from your services. But first, the provider. What does that look like?
We're a diverse network. There's really not a typical day. There's many different provider types. I'll just use a few examples. If you're an assertive community treatment team provider, that's an evidence-based model. That's a high-intensity, team-based, field-based approach to addressing the needs of people with severe mental health concerns. Your day might start off with a team meeting. You're going to decide who each person is going to visit that day. Then you go and do the actual visits, and those visits might take place in a hospital if the member's hospitalized. It might take place at the person's home. It might take place wherever you can find the member. The intervention might be a clinical intervention. It might be helping the person attend a medical visit. It might be any number of skill building exercises. We have other providers that work in substance use disorder treatment programs. So that's a person who might be leading group therapy or meeting individually with someone, doing some skill building around relapse prevention. We have other providers that are psychiatrists that might be meeting with someone after they were hospitalized to ensure medication continuity. We have nurses in community health departments who are helping people synthesize all aspects of their care. There's people that work at providers that are people with lived experience who are going to where people with housing instability tend to congregate and try to build relationships and rapport that would support a more formal treatment engagement down the road.
So what does a typical day look like for someone? Again, I know there's no one typical, it ranges, but if you can distill it into sort of a template, if you will, for someone who benefits from your services.
Yeah, I think that people are benefiting from an interaction, an open-ended interaction with the provider, where the provider is approaching them in a non-judgmental fashion and really trying to get at what the needs are in the member's frame. There's this statement, when you're a hammer, everything tends to look like a nail. We're not trying to just apply treatment to people. We're trying to see what the goals are in their frame, build rapport, build engagement, and then, let the member avail themselves of the tools in the provider's toolkit. I think that something to point out about the members is that it's possible to have very positive treatment outcomes, even if you've got an addiction issue or a severe mental health concern. You can live a happy life. You can live in accordance to your values and goals. I think something that's important for observers of the system to know is that this is predominantly a vulnerable population. This is not a dangerous population. In fact, people with severe mental health concerns on the average are less likely to be violent than everyone else. Without treatment and support, it's a sad reality that many of the people we work with don't have safe or consistent places to live. They might have troubling mental health systems. They might be troubled by recollections of traumatic events. But with the treatment we talked about, they can make gains across the board: behavioral health, primary care. And that's really what the intervention looks like, is an open dialogue. What are the members' priorities? What's helping the member make gains with what their immediate priorities are, and helping build that rapport so that they can target a whole range of healthcare conditions.
So your services are provided across the state of Illinois. Any plans to go to other states?
Right now, we're restricted via our operating agreement to operate only in Illinois, but the conversation has been broached with our board of managers, and we look at that strategically on an annual basis in our board strategic planning sessions.
Okay, but fundamentally, it shouldn't be a problem in taking this from state to state. I don't know what all the red tape and all the other restrictions are, but it seems to me this is a repeatable service or foundation.
The service is repeatable, Charles. What's not is the commitment of provider leaders to engage in this type of work. So one of the secret sauces of IHPA, if you will, is the commitment of the management teams at each of our 100+ providers to make the changes necessary in their day-to-day operations to succeed in this type of contracting model. And that is not something that is easy to do. It requires a great deal of change organizationally, and it really, truly depends on the commitment of the senior leaders in each organization to push this down to the frontline staff members in their organizations and to change the way fundamentally the providers do their work. We have been extraordinarily successful because we've had a senior leadership team in each of our providers that has committed to doing so. So we've educated our providers, we've given them the tools, we've negotiated the contracts, but they implement the model in accordance with their own individual operations. So we don't dictate to our providers how they should treat a member or what they should do to treat a member or give them those strict guidelines, because from our perspective, all 120+ of our providers have different operational dynamics.
Right.
And it's up to the individual organization to implement in the way that they see fit for their organizations to be successful. So we have built an extraordinarily successful organization, and part of our success has been that level of management engagement that is fundamental to making sure these types of models work.
I'm going to ask you a probably delicate question, but what does the future look like with the pending cuts to Medicaid? You had to know that question was coming.
Yeah, sure. Well, you don't know until you know. So right now we have some general ideas of when cuts may occur and what cuts may look like. But each state, because each Medicaid program is managed by all of the 50 states, each state manages their program differently. So we have to see first how the changes that are pending are going to impact Illinois. And then we will see subsequently how we need to respond as a provider organization. Obviously, the biggest impact is going to be a loss of covered members as benefits are either pulled away from folks who currently have those benefits, or are new requirements such as the work requirements are put in place that may impact a member's eligibility and subsequently their ability to be attributed to one of our contracts. So right now there's more questions than answers, and we have to wait to get the specifics, which will start to flow out of Washington and down to our individual states shortly here, and then we'll dissect and have a much better sense of the implications it will have on the organization.
Yeah. Any final thoughts, gentlemen? Gilbert?
I would just add that I think our focus on value, our focus on the holistic well-being of the member is something that everyone can buy into. And we describe this to providers as a way to future-proof themselves. The work that they do through us is a way of being ready to participate in any value-based agreement that might come down the pipe.
Excellent. Gentlemen, I really do appreciate your time in walking us through this.
Thank you.
We appreciate the opportunity, Charles. Thanks so much.
My pleasure. Today, I spoke with David Berkey, Chief Executive Officer, and Gilbert Lichstein, Chief Operating Officer of the Illinois Health Practice Alliance, a clinically integrated behavioral health network promoting health recovery, engagement, and choice to clients across the state of Illinois. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.